Moving to case 4, this is routinely we used to see in cirrhosis with hepatitis B, usually with patients with cirrhosis and ascites or cirrhosis with HCC cases who requires transplant with high viral load, how to manage and in this case scenarios. So this is the case of hepatitis B viral cirrhosis with HCC. He was diagnosed as hepatitis B virus underlying cirrhosis 20 years back, took treatment for 10 years, then after that he took CAM, and history of jaundice 6 months ago, and history of pain abdomen 3 months back. He was evaluated and diagnosed to have HCC with 5 into 4 centimeters lesions and no decompensation in past, evaluated for liver transplant, came to us. Examination wise, no other specific findings. So his LFT bilirubin is 1.3 with AST is 85 and ALT is 47, albumin is 3.7 and hemoglobin is 12.2 and counts for 7,000 with platelets are good, and AFP is 90 and PUCA is normal, and his viral load is almost log 8.3, and if you see CT scan, there is a lesion in segment 6 which is almost 5 into 4 centimeters. Along with that there are some 2 lesions with 1 centimeter. So my diagnosis is hepatitis B-related cirrhosis with well compensated, with underlying portal hypertension, with non-bleeder, grade 1 varices, with CTP5, with MELD of 12, the BCLC-B HCC, multifocal, with the largest lesion 5 into 4 centimeter, with SUV is 2.94. And there is no involvement of portal vein and there is no distant metastasis. So what will be the next line of management, and in this case, what will be the significance of high viral load in liver transplant settings? Dr. Sharath sir.
So the first question is, what is the next line of management? Obviously, you have to address the cancer and as well as the virus. So I got the part that the largest is 5 centimeters. How many other lesions you said there were?
Total 3 lesions are there.
Okay.
And the next 2 lesions are 1 centimeters, and third lesion is 5 into 4 centimeters.
Okay. So in terms of treating I'm assuming this patient is going to be waitlisted for transplantation, and you might want to bridge the patient while he is on the waiting list.
Yes.
So the bigger lesion may be amenable to treatment. So you might want to do TACE, which is very well compensated. There's no portal hypertension as well. So, and it depends on the socioeconomic setting as well. So you could do a TACE as well as a microwave combination to the bigger lesion, because it's around 4 to 5 centimeters. It may be amenable to that combination therapy. And in terms of high viral load and the significance in the transplant setting, so at the time of transplant, if you have an aviremic patient, if you've instituted antivirals and your patient is aviremic, you may be able to avoid giving hepatitis B immunoglobulin through your transplant, as compared to a patient who has detectable viremia, where you might have to give some amount of immunoglobulin in the anhepatic phase, if not for a few more doses later on. So yes, you would discuss about transplantation, waitlist the patient, maybe talk about the options for bridging therapies, and starting on antiviral agents.
Yeah. So for this case, because of high viral load and multifocal SCC, we explained to the patient to wait for transplant for time being. So we started on dual antiviral drugs, tenofovir plus entecavir, and for largest lesion we have done TACE to that lesion. After 1.5 months, we have repeated DNA, which was log 4, and repeat PET CT showed complete response for the lesion, and there is no new lesions were not there. And AFP from 2090, it has come down to 12.3 nanograms. So this case, how long to wait for HBV DNA levels to come down for liver transplant? And second question, in this scenario, ideal cutoff for HBV DNA levels in setting of underlying multifocal HCC background. Dr. Sukanya ma'am.
Since this patient after 6 weeks of therapy has complete remission, I would wait for the DNA to come down to not detectable levels.
Okay.
There is no hurry to transplant at that point. But otherwise, at least a 10 power 3 is what we should aim for to go for a transplant. But
So-
in this patient, I would wait till it becomes undetectable.
So-
For the same reason as what Dr. Sharath said, you can avoid immunoglobulin. Not just that, you can avoid a reinfection and so many other things subsequent to that. And then you also increase the chance of patient becoming HBsAg negative post-transplant, responding to vaccination post-transplant if you go with undetectable viral load.
So this patient is already underlying multifocal SCC, maybe chances of...
But then we have seen that the other
Yeah.
two lesions are 1 centimeters.
Yeah.
You know, 1 centimeter lesions do not get any BCLC, any exceptions. So not BCLC, so they don't get any MELD exception points. They should be at this, treated the same way as a patient without HCC. And the bigger lesion has gone into complete remission. In 3 weeks, if the viral load has come down from 10 power 8 to 10 power 4, then it's quite, in 6 weeks, it's quite likely by 12 weeks it would be undetectable.
Sharath sir, you have...
You could argue that this is outside the conventional criteria, right? So instead of rushing into a transplant for the fear of the cancer recovering during waiting, instead you might actually want to wait because you've bridged the patient. You want to uncover the biological behavior.
Yes.
So if your patient is recurring that fast, then your prognosis post-transplant may not be good. So it is paradoxical, but because it's outside the criteria and now you've bridged the patient, you might actually want to wait and see the biological behavior.
And also another thing, when we downsize patient tumors, it is expected that you follow them up for a finite length before you can take them for transplant without significant chances of a recurrence of tumor. So for 2 reasons, obvious. One is for the viral load and the other is to uncover the biology of the tumor.
So in these settings, we explain the patient that to become HBV DNA to go for undetectable levels, but family are little hesitant to stay. So in this case, HBV DNA is log 4, post-test it showed complete response, AFP is 12.3, waited for almost 1.5 months. So option now is wait till for HBV DNA to go for undetectable or liver transplant with the support of immunoglobulins in this criteria. Sachin sir?
Actually, when we decided to downstage, that time only we would like to see whether patient is going to be for a living donor or a cadaveric transplant. Suppose if he is for a living donor transplant and we have identified the donor,
Yes.
we would like to do some fast vaccination for him so that he has antibodies in him prepared by the time they go ahead with donation. And we will definitely like to go ahead with transplant if patient is willing and they have a donor immediately. Suppose if he is for cadaver, anyway we have to wait for HBV DNA to come down and even organ is not available. So in those cases we would like to wait. But if living donor is there, we will definitely like to go ahead. And even immunoglobulins, we usually give low dose immunoglobulin to these patients and then follow only with antivirals.
So in this case, he is evaluated for LDLT, his donor is there. So we proceed with liver donor transplant. So with continuing dual antivirals, along with that we have given intraoperatively anaaphatic phase almost 10,000 international units given, followed by daily 1,000 units for 7 days, and then weekly once for 1 month. So we kept his anti-HBs status almost 230 at 1 month after transplant. So in this case, how long to continue immunoglobulins in this case? Dr. Sharath sir?
I think that's a difficult question to answer. So we could say that at the time of transplant, the viral load is not high, it's in the intermediate range, right? So you've treated the patient for a week. If you went back to traditional protocols, we used to treat them for a few months, in fact for a few years. Some of these patients used to get HB. So I think for this patient, at least for the first 3 months, I would maintain a serum HB level more than 100 at least, and while maintaining the patient on antivirals. End of 3 months, again you could argue, do you go once a week with your HB? How much do you go? How many units do you go? So it's a bit hit and miss, but you continue the antivirals and check your surface antigen. And if your surface antigen remains negative and your titers are above 100, I would maintain that for maybe 2 to 3 months and then switch over to the antivirals after that.
Sukanya ma'am, any comments on this?
I think from Asia Pacific, the subcontinent, HBIG is very rarely being used. But since this patient was viremic at transplant, I would give him HBIG for maybe a year to keep anti-HBs levels at more than 100, and then antivirals forever.
So our plan is to keep immunoglobulins 1000 units monthly once to keep at least for 1 year, along with to continue antivirals. So second question, how long to continue antivirals in post-liver transplant setting and how to monitor in these cases?
You need to continue it.
Yes.
You just need to continue it. You could monitor the HBsAg yearly.
Okay.
It's every 3 months for first year and then yearly. And then if you're vaccinating the patient after a year, you could check the anti-HBs levels also. But then they have, there are periods, transplant patients, there are periods when they are HBsAg negative, and then that alternates with periods where they are positive. So it's a very fluid situation. I don't think any of us would like to stop antiviral even if the patient is HBsAg negative.
Any comments, sir?
Yeah, at the moment, I just practice continuous antivirals, but I'm aware of studies, particularly from the Oriental countries, where after a few years post-transplant, if your HBsAg is persistently negative, then you could consider, and if your immunosuppression has come down to a lowish level, if your core antibody is negative, you could consider vaccinating these patients. And if you're able to build up their anti-HBs titers, a few years down the line, you could consider getting the patients off antivirals. I've been able to do this for a couple of patients, but that was serendipity because the patients were complaining about severe muscle pains with tenofovir, and so they were reluctant to continue with that, and they had a bit of renal dysfunction. They happened to slowly try this on these patients and take it off, but I practice just continuous antivirals.
So it's a last question. In patients, routinely sometimes we used to see reactivation of hepatitis B or acute liver failure maybe due to hepatitis B. So we were preparing for liver transplant. So these cases, how to prepare for pre-op and intra-op and post-op? Sachin sir, is any comment on this?
In this scenario, means if they are for living donor, we will definitely give 1 shot of vaccine to the donor, and then definitely these patients will be started on dual antivirals. And depending on level of HBV DNA, they will be treated with intraoperatively. We are a follower of a low dose immunoglobulin in such situations, and even on occasions we don't even give immunoglobulins.
Any comments, sir? Sukanya ma'am. In these cases, reactivation of hepatitis B, if DNA is very high, is waiting for going for transplant, LDLT.
I think if patient is in ALF, there is a donor available, whatever, regardless of the viral load, start the antivirals and then take the patient up for transplant. Since it is ALF due to hepatitis B, a non-immunocompromised patient would have a good chance of becoming HBsAg negative, but this patient may not become. Health will need to be continued on antivirals.
Sir, any comments, sir?
Just digressing a little bit, but I think a lot of healthcare professionals who are not adequately vaccinated against hepatitis B. I'm sure some of them in this hall would not know what their anti-HBs titers are. So I think, and if you're a surgeon, you're handling a patient with ACLF, you're going to have very high viral loads. So you're better off checking your vaccination status as well.
So ideally in patients with hepatitis B, the DNA level should be undetectable levels before transplant, but it might be depending upon the case basis because of underlying liver tumors where there is chance of metastasis. These cases we can, in setting of LDLT, their immunoglobulins can be helpful to decreases the post-transplant recurrence of hepatitis B. So thank you, ma'am. Thank you so much.